Good afternoon, everyone. I am Dr. Anu Bharti, PG2 from the DMCS Darbhanga. My topic of presentation is congenital aniridia. No financial disclosure. A 6-year-old male child came to the IOPD and his mother complained of his decreased visual acuity in both eyes and increased sensitivity to light and difficulty in focusing on objects. Parents reported occasional discomfort when exposed to the light since birth and abnormal movement of eye noticed at 1 year of the age. Patient had full-term normal delivery with normal weight. Child had completed all doses of vaccination, no previous surgery or systemic illness. His mother and his aunt has also similar presentation and abnormal movement of the eyeball and aniridia. On ocular examination, visual acuity is finger count close to face in both eye and horizontal nystagmus present in the both eye. Eyelid, adnexa and conjunctiva were within normal limit. Cornea is clear in the right eye and clouding with signs of superficial vascularization around the limbus present in the left eye. Absence of the visual iris in the both eye. No pupillary aperture present in the both eye. Clear lens in the right eye and the mild anterior polar cataract present in the left eye and poorly developed angle structure present in the both eye. Fundus where foveal reflexes are not seen and the vessels seen over the fovea. Intraocular pressure were within the normal limit. On systemic examination, developmental milestone and the neurological examination were normal. On investigation, ultrasound abdominal, no abnormality found in the kidney. Chest X-ray and the CBC were within the normal limit. Genetic testing, PAX6 gene testing was advised. Differential diagnosis are the Weger syndrome, Axenfeld-Rieger syndrome and the albinism. Management includes visual rehabilitation, spectacles with tinted glasses for the photophobia and the low vision aided provided for the visual therapy. Corneal protection, lubricating eye drops were started to reduce the risk of the keratopathy and the patient was educated about the need of the regular follow-up to monitor the progression of the aniridia-related keratopathy. Cataract, since there is the early signs of the cataract, patient will be monitored every 6 months to assess for the progression of the cataract. Glaucoma screening will undergo regular IOP measurement along with gonioscopy to monitor the anterior segment angle structure. Genetic counseling were advised as it is autosomal dominant for the risk of the future offspring and the possible systemic implications. Regular renal ultrasounds were advised. Discussion. Aniridia is a rare congenital disorder characterized by the partial or the complete absence of the iris in one or the both eye. It is typically inherited in autosomal dominant manner associated with PAX6 gene mutation on the chromosome 11p13. Other phenotypes are the congenital sporadic, includes Weger syndrome and the autosomal recessive associated with cerebral ataxia and the mental retardation seen in the Gillespie syndrome. Ocular manifestation includes photophobia, nystagmus, decreased vision, amblyopia, strabismus, secondary to the foveal and the optic nerve hypoplasia. Other ocular abnormality includes corneal opacification, cataract and the glaucoma and the foveal hypoplasia. Management of the aniridia, it involves multidisciplinary approach. Iris defect is managed by the colored contact lenses, corneal tattooing and the corneal stromal implants. Corneal protection includes mild keratopathy can be managed with topical free lubricants and the moderate and the severe keratopathy is treated with autologous serum and the amniotic membrane transplant. Early detection of glaucoma is useful for the prophylactic anti-glaucoma, but prophylactic goniotomy is quite effective in the preventing or delaying the onset of the glaucoma. Cataract monitoring is the essential and the genetic counseling were advised. Cataract management is essential. Specialized intraocular lenses that incorporates an artificial iris diaphragm can be used to correct aniridia at the time of the surgery. Conclusion. Aniridia is a rare congenital disorder with significant implication for the vision and the overall health. Though there is currently no cure for the condition, early diagnosis and the regular follow-up and a provocative management approach are the key to minimizing complication and can significantly improve the quality of the life. This case highlights the critical role of the ophthalmologist, geneticists, and the pediatrician in the care of the aniridia patient, ensuring comprehensive management of both ocular and the systemic manifestation. These are my references. Thank you.
Avinash wala. I am presenting a case of bilateral megalocornea and ectopia lentis in an 8-year-old female with a Trabulsi syndrome. So the patient presented with bilateral megalocornea and supranasal ectopia lentis with visual impairment. She also exhibited glaucomatous cupping and craniofacial dysmorphism. Trabulsi was diagnosed via genetic analysis. Aspartate beta hydroxylase gene defect was found to be the culprit. Sequential bilateral lensectomy with CMT flex was planned. Trabulsi syndrome is a rare autosomal recessive disorder due to ASPH gene mutations characterized by megalocornea, ectopia lentis, filtering blebs, and earlier glaucoma. The systemic features include triangular facies, downward slanting palpebral fissures, and beaked nose, diploic space widening, which is a spongy bone present at the base of the skull. Early recognition prevents amblyopia and glaucoma-related vision loss. The pathophysiology involves there is disruption of the hydroxylation of EGF-like domains in the extracellular matrix proteins, which causes zonular weakness, ultimately leading to ectopia lentis. Trabecular dysgenesis is also present, which predisposes the patient to glaucoma. And ASPH gene defect disrupts craniofacial mesenchyme, which causes facial dysmorphism. So this was a child which presented with the downward slanting of the palpebral fissures. There were normal birth and milestone history, siblings were unaffected, and no family ocular disease were present. In the right eye, vision was finger counting 1 meter, finger counting 3 meters in the left eye. Both eyes supranasal subluxated clear lens was present. Both eye megalocornea 13 mm in height and 12 mm both eyes. Ectopia lentis was present in both eyes. In the left eye, there was cupping which was 0.7 and early glaucomatous changes were also present. On systemic examination, echocardiography and other systemic causes were ruled out, or other systemic problems were not there. Apart from the fact the craniofacial triangular facies, beak nasal bridge, downward slanting, and palpebral fissures were present. So the diagnosis of Trabulsi syndrome was made, and the other differentials were ruled out on the basis like Marfan's was ruled out. There's usually a supratemporal ectopia lentis and Marfan's with systemic skeletal and cardiac features. In Wheel Marchesani, there is microspherophakia, brachydactyly, and short stature, and homocystinuria infranasal ectopia lentis is usually present. And isolated ectopia lentis is associated with gene ADAMTSL4, which is related to just isolated ectopia lentis. The complications post-treatment can be usually a clear lens extraction followed by leaving the patient aphakic and contact lenses usually, which is mentioned in the literature, but due to the fear of losing this patient for follow-up, we did CMT flex in this patient. There is risk of secondary glaucoma, angle block, or the trabecular dysgenesis can be the mechanisms. Other risks, retinal detachment, other maculopathies, corneal decompensation, and phacotoxic uveitis are some of them. We should be worried about the glaucoma part, which should be managed medically and surgically. And we should usually avoid in the bag IOLs because of the presence of zonular weakness. Early intervention prevents amblyopia and optic neuropathy. So both of them has like Trabulsi mimics Marfan's in Wheel Marchesani, but there is filtering blebs in the case of Trabulsi, and no systemic features usually are present in Trabulsi. Genetic confirmation is idle when you are always confused between all these situations. Genetic counseling is recommended for the families as well. Timely lensectomy, amblyopia therapy, and glaucoma surveillance are the three important bases that forms the treatment and management of Trabulsi. Thank you.
Good afternoon, everyone. I'm Dr. Kiran Deep Kaur, Senior Resident from GMC Doda. I'm here to present a case report on Lawrence-Moon-Bardet-Biddle syndrome. It is a rare autosomal disorder characterized by retinitis pigmentosa, obesity, hypogonadism, mental retardation, and polydactyly. It mostly occurs in children born from consanguineous marriage These patients generally show symptoms within first decade of life with poor night vision, usually this being the first symptom in children. The prevalence of LMBBS is estimated to be 1 in 1,60,000 individuals. Only a few cases were reported in India, so basically we are presenting a rare case of LMBBS. In this report, we present a case of 13-year-old boy who presented in our OPD for disability certificate for vision impairment. He had chief complaints of decreased vision, which was more pronounced in night. Antenatal, natal, and postnatal events were uneventful. He was delivered through normal vaginal delivery. The developmental milestones were achieved except for decreased intelligence as compared to the children of other age group, inability to understand, inattentiveness in school, and addiction to phone. Personal history revealed he had no history of polydipsia and polyuria, which rules out renal disease and diabetes mellitus, which is very important concerning factor in this disease. Then family history revealed that both mother and father had consanguineous marriage. His physical examination revealed BMI was 34.6, which indicates obesity. He was hemodynamically stable. All vitals were normal. Physical examination revealed he was obese, lethargic, short-statured, with pedal edema and facial puffiness, which is quite evident in this picture. On further examination, there were hyperpigmented macules on his face. Polydactyly was present in his right foot. There were 6 digits. Then further examination revealed that he had undescended testes, untraceable right one, and a left small depigmented scrotum. Then on ophthalmological examination, his visual acuity was 3/60, which got improved to 6/36. Nystagmus was also present. Fundus examination revealed pallor of optic disc, bilateral attenuation of vessels, and retinal pigmentary changes. OCT scan showed rod and cone dystrophy, which is quite evident in this picture in ellipsoid zone. Then lab investigations were almost normal, normal HV, normal CBC. His lipid profile was deranged. Glycosated hemoglobin was on bit on higher side. LFTs and KFTs were normal. Along with this, several hormonal tests were done. ECG, echo, and audiometry were all normal. Ultrasonography revealed left testes undescended and right one untraceable. Genetic evaluation was not done as it was not financially feasible, plus it's not available in our institution. Then in some history regarding it, in 1886, Lawrence and Moon first described a case with mental retardation, hypogenitalia, polydactyly, and obesity. Later in 1920, Bardet described it. Then later, Beadle explained 2 cases with findings of mental retardation, GI problems, and skull. It was termed as LMBBS. It is a pentade of these 5 features. Then secondary features include renal impairment, speech delay, congenital heart diseases, ataxia, anosmia, hyposmia, dental problems, and then diabetes mellitus. Prognosis. Overall prognosis of disease varies. Untreated obesity and vision problems are basic problems. Most frequent complications include end-stage renal disease and blindness. Despite these serious health problems, these patients are remarkably happy. Treatment. There is till now no known remedy is available for it. Major focus is towards improving the quality of life, decreasing mortality and morbidity rates. Regarding education, the use of braille, computing skills, large printing material. Then obesity control by healthy diet and regular aerobic exercises. Hormonal replacement, regular screening, and rehabilitation. Then comes awareness and counseling, which is very important in this case, as these cases are linked with consanguineous marriage. Also, the marriage outside the family should be promoted. Family counseling should be done. Conclusion. This is a rare case which mostly goes unidentified by various clinicians. Thorough history taking and a clinical examination is very important in this diagnosis. Renal involvement is considered a deadly parameter which was obviously not seen in this case. Genetic counseling can help families to understand and manage the LMBBS risk. Thank you.